Well, I see a lot of people coming in. Thanks for everybody for joining us this evening. We're just going to give it a couple more seconds and we'll get started. I see a couple more people coming in, which is great. Okay, perfect. Good evening and welcome. I'm Kevin Edwards of Allied Physicians Group. Thank you for joining Baby Basic webinar series. This is our 10th during this time, and we hope you get a lot out of it tonight. Tonight we'll be focusing on prenatal breastfeeding. Our hope is to provide you with valuable answers to the many questions you are facing. A few housekeeping details before we begin. If you have additional questions, you can use the Q&A feature located at the bottom of the screen, and we'll address as many as we can at the end of the webinar. And then following this webinar, we'll send out a link to the presentation as well as share other useful resources. Typically, we'll put together a Q&A off of the questions that we can't answer at the end. We thank you again for joining us. I would like to introduce Dr. Kerry Fierstein from Allied Physicians Group, who will be leading our discussion this evening. Dr. Fierstein?
Hi, everyone. Kevin, should you see me in the little window?
I see you.
Okay, because I see you, but okay. I'm Dr. Kerry Fierstein, Chief Executive Officer of Allied Physicians Group, a practicing pediatrician for 30 years, a mother of 3, and 10 weeks ago I became a grandmother. So I've seen firsthand all of the excitement and concern that comes with having a new baby. It's an exciting time, but also a time for a lot of worries. And am I doing things right? New parents want to do everything right, but they're not sure, what the right thing is. So you've taken that first step tonight, because not only are you going to get some great information on how to breastfeed, but you've also picked a source for your information. And there's so many decisions you're going to have to make every single day, and you can't research all of them, as wonderful as the internet is. So it's great to have a source, and Allied Physicians Group is a great source for you. We're primarily a pediatric group. We're an independent group, which means we're able to make the best decisions for our patients. We have offices all throughout Lower New York. And we're here for you. If you are looking to pick a pediatrician you haven't done yet, all of our groups do prenatal consults. We can do them by Zoom, or we can do them in the office, depending on where we are in the COVID situation. And we're all happy to be here as a resource for you. So tonight we're going to be doing a presentation that focuses on breastfeeding. You may want to check out the presentations that we did earlier on newborn basics and baby basics, and you can get those on the alliedphysiciansgroup.com website under education and baby basics. So tonight I'm going to introduce our lactation consultant pediatricians. So Allied has a focus on breastfeeding medicine, and I'm going to let them introduce themselves to you. So Dr. Shaer, you want to introduce yourself?
Thanks so much. My name is Jennifer Shaer. I am the Chief Medical Officer of Allied Physicians Group and a general pediatrician practicing in Riverhead and Southold on the east end of Long Island, and a lactation consultant, breastfeeding medicine specialist.
Dr. Visentin?
Hi, I'm Dr. Visentin. I have the privilege of working with Dr. Shaer. I am one of her coworkers in the office in Peconic Pediatrics, and I do both general pediatrics and breastfeeding medicine with her in our offices.
Great. And Dr. Macaluso?
Hi, I'm Dr. Lauren Macaluso. I'm also a board certified pediatrician and lactation consultant, and went all in with an exclusive breastfeeding medicine practice that I've been at for 15 years now. I have 2 college-aged kids that are working out and cooking and enjoying themselves as much as they can while we're home together. Proud to breastfeed them and really dedicate my medical life to breastfeeding.
Great. So we're going to give the presentation. You guys can do some, put some questions in the chat. We'll see what we can get to during the presentation. And then we'll also have some questions at the end. So Dr. Macaluso, it's all yours.
Thanks, Kerry. So I'm going to start out with why breastfeed. Medical and public health organizations recommend that babies be exclusively breastfed for 6 months, with introduction of solid foods around 6 months and continuation for a year or more, pending mom and baby mutual desirability. The American Academy of Pediatrics states that there's no upper limit on the duration of breastfeeding and no evidence of psychological harm from breastfeeding into the 3rd year of life or longer. The American Academy of Family Physicians includes the ongoing benefits of extended breastfeeding, including continued immune protection, better social development, and having a sustainable food source in times of emergency. Breastfeeding is designed to meet the needs of babies and moms. It has the right amount of carbohydrate, protein, fat, and water for optimal development. It's easily digested and it's dynamic. It changes composition throughout the day and over time to match the needs of our growing babies. It has bioactive factors that protect your baby from infection, modulate their immune system, and affect growth and development. We tend to like to use mnemonics in medicine to help us memorize things, and a neat breastfeeding medicine colleague at the University of Wisconsin shared this one for the bioactive factors in human milk. And she used the term ACE choices, A standing for antibodies, C for cytokines, E for epidermal growth factor, C carotenoids, hormones, oligosaccharides, interleukin-10, cells that fight infection, and essential fatty acids for neurodevelopment. Breastfeeding is normal. It's not best. It's not a special sauce. It's just normal. It's what mom and babies are meant to do. And it's so much more than just food. In an ideal normal vaginal birth, we deliver the baby. Baby goes to the mom's chest within the first hour of life. Newborns that are kept in skin-to-skin contact on the mom's chest have better body and skin temperatures. And believe it or not, the blood flow to the mom's chest in a new mom postpartum is more than the blood flow to your brain. It's a super important place to be. So breastfeeding is warmth. Newborns utilize their senses and instinctive abilities to breastfeed. They actually have the scent of amniotic fluid from inside you on their hands when they're born, and they lick their hands and work their way towards the breast to help them attach. And believe it or not, your sweat and secretions from the glands on your dark circle of your breast, also known as your areola, smell and taste familiar to your baby, similar to that amniotic fluid. Newborns have a visual preference for contrast, and there's this big giant dark circle with a bullseye ready and waiting right for them to attach to you. So all of these inputs make breastfeeding normal and instinctual. Oxytocin hormone is produced in both the mother and the infant's brains during breastfeeding, and it's also known as the love hormone that helps with bonding. Early milk, known as colostrum, comes in small amounts. It's high in antibodies and protects your baby from what you're both exposed to. The average intake of colostrum in the term, meaning coming out close to your due date, healthy newborn, is only about 1/2 to 2 teaspoons per feed on day 1 in the first 24 hours, which increases in response to your infant's needs. Many of us question our abilities to make enough milk for our babies and feel the need to utilize formula as more food. But remember, breastfeeding is so much more than food. It's not just food. It's human instinct, it's warmth, it's bonding, and it's what we're supposed to do. Next slide. So making the decision. The challenge is breastfeeding may not feel that instinctual right about now. Most of us are facing barriers to breastfeed, even not during pandemic conditions. We're living farther away from our extended family, and it's challenging to find support. Many of our mothers didn't breastfeed, and society has not fully embraced this as normal yet. Most of us are having a hard time finding evidence-based consistent information about breastfeeding. We're receiving mixed messages and often we don't know who to believe. We're returning to work with varying levels of support to be home to establish breastfeeding or to establish a flexible work plan to breastfeed and express milk. When breastfeeding problems occur, we don't always know where to turn. This is a physical, mental, social, and emotional climactic transition, which can be challenging to handle. And it's known as the 4th trimester. Remember, it's totally normal. There's evidence-based help out there and you're needing it right now. This is when breastfeeding is so much more than food. You burn 500 extra calories a day with breastfeeding and thus usually return to your pre-pregnancy weight more quickly. You mobilize fat stores, you reset your metabolism, and you have a decreased rate of diabetes, hypertension, and cardiovascular disease later on. Oxytocin, that love hormone that we mentioned that helps with bonding, it also stimulates smooth muscle contraction of the breast-producing cells in your breast and the uterus, and thus you have less bleeding after delivery and less anemia. You're less likely to ovulate while breastfeeding exclusively, which helps with child spacing as well. And you have a decreased risk of ovarian and breast cancer. And your baby has a decreased risk of infections, including ear, gastrointestinal tract, lower respiratory tract, and a decreased risk of sudden infant death syndrome, childhood obesity, and diabetes. It's important to include that the breast, and thus breastfeeding, is not perfect. Some of us have physical, social, and emotional reasons where we're unable to breastfeed, have a need for alternatives, or make a choice not to. It's recommended to supplement a baby with expressed breast milk, safe pasteurized donor human milk, or formula if there's a medical indication, such as inadequate milk intake in the baby, with signs being excessive weight loss, inadequate urine and stooling pattern, or excessive jaundice. Many moms and their partners express frustration, stating, "I'm told I should breastfeed, but I'm receiving little to no hands-on help and consistent help to help execute this." Hands-on, time-intensive mom and baby care should be universally included in healthcare, but we're not fully there yet. It's our goal to support you and help you reach your goals. And this should be through informed, educated, non-judgmental decision-making and thorough care with you and your family. Okay, quick medical school. How it all works. There's 4 major hormones in lactation: estrogen, progesterone, prolactin, and oxytocin. Estrogen and progesterone are released from the placenta during pregnancy, and these help to increase the size and number of milk ducts in your breast. Once your baby is born and you deliver the placenta, these hormones decrease and prolactin increases. Prolactin is your milk-making hormone. It's secreted in a pulse-like fashion from your anterior pituitary gland. It rises with suckling, so the more feeds, the higher level of prolactin. Milk production runs by, a lot of us say supply and demand, but it's usually like the reverse. It's demand and supply. A common phrase we use is an emptier breast makes more milk. Milk production slows when the breast is full, and it speeds up when the breast is emptier. There are actually prolactin receptor sites on the walls of your milk-producing cells. When full, the walls of these cells expand and they can change the shape of the prolactin receptors, so prolactin can't enter and milk production goes down. As milk empties, prolactin from your bloodstream can then move in and stimulate breast milk production. Oxytocin, we talked about bonding, love hormone. We talked about uterine contractions, decreasing bleeding, less anemia, and it also causes smooth muscle contraction of those cells lining the milk-producing cells. They contract and it stimulates letdown, as we call it, or the milk ejection reflex. That secreted oxytocin from your posterior pituitary gland, and it helps to push down the duct and the milk, contract the milk and push it down the ducts towards the nipple. So once again, breastfeeding is normal, and normal is pretty darn amazing, I think. And now I'm going to hand things off to Dr. Visentin for how to get off to a good start.
All right, you guys can hear me now? Thank you, Dr. Macaluso. So I'm going to talk a little bit about how to get off to a good start. And I'm going to talk a little bit actually before you deliver. Obviously, coming to this presentation is one of the first things that you can do to start educating yourself. I also encourage you to discuss what your plans are, both with your partner, the people in your family who are going to be helping you afterwards, and with your medical providers, your OB or your midwife, whoever is going to be with you in the delivery room, so that they know what your wishes are, and talk to them a little bit about what the procedures are in the hospital after you give birth. Ideally, if you have a normal vaginal delivery, everybody is healthy, mom and baby are healthy, that baby should be put to mom's chest immediately after birth, as soon as it's medically appropriate for that to happen. And that skin to skin will help you get off to a good start with breastfeeding, as Dr. Macaluso already mentioned. Ideally, within the first hour, the baby will start to have their first feed. If moms are having a C-section, either a planned or unplanned C-section, breastfeeding can still happen fairly quickly after delivery, again, assuming that mom and baby are medically stable. If you are going to be having a planned C-section, talk with your medical provider about what their policies are after that. Most hospitals now are moving towards allowing breastfeeding in the delivery room if that is the wish of the mother. And so that's something to discuss, as I said, both with your partner and with your medical provider, so that you know what the policies are in the hospital or the place where you will be delivering, and you can work towards having that happen. In that first day of life, your baby is going to be a little bit sleepy, but still need to feed often. I'm going to talk a little bit about in the next slide about some feeding cues and how to know that your baby is getting enough. But you're going to be looking for things like the hands to the mouth. The baby are going to kind of move their lips, start sticking out their tongue. Those are early feeding signs. And those are the things that you're going to be looking for to know when you should put your baby to breast. Crying is a late sign of hunger, and so ideally you would be starting to recognize those signs earlier before the baby is crying. Put the baby to breast at that point. Most babies should be eating 8 to 12 times in a 24-hour period. So a lot of times you'll hear people say every 2 to 3 hours. That's where that kind of comes from. And so you're looking for a goal around that 8 to 10, 8 to 12 times in 24 hours. In the hospital, most of them have lactation specialists. A lot of the nurses are trained as well. So don't be shy about asking for help. This is maybe the first time that you've done this. If this is your first baby, you could read all the books, go all the webinars, be the most educated person, and then you have this little human being in front of you that is brand new to you. You've just had a baby, and it's the first time that you've done this. And so it's great to get all the information ahead of time, but until you have that little baby in your arms, it's not something that you can necessarily practice ahead of time. And so ask for that help. Have somebody watch you in the hospital. If it's not feeling comfortable, if it's painful, ask for help. Most people, or I shouldn't say most people, some people are familiar with the term that says your milk is coming in. That is a bit of a misnomer. You've been making milk for a long time before you deliver your baby. However, that transition tends to happen between day of life 3 to 4 after the baby is born. And so that's when you'll notice the higher volume of milk. Your breast typically will get fuller. So you are definitely making milk before that. As Dr. Macaluso explained to us in the previous slides, the more often you put your baby to breast, the more milk you will make. So when in doubt, put the baby to breast. That will help you increase your milk supply and make sure that your baby is eating enough. Next slide, please. So how do you know if your baby's eating enough? This is a breastfeeding log that hopefully you guys have a copy of or will have a copy of at the end of this. And it gives you a little bit of a guideline about how often your baby should be breastfeeding, and then how your baby is peeing, how often your baby is peeing and pooping. We keep track and ask you to keep track of how often your baby is peeing and pooping, especially in that first week. That helps us get an idea. You won't know the exact volume of breast milk that your baby is getting if they're directly breastfeeding at the breast. However, if your baby is peeing and pooping enough and they're feeding frequently enough, that's how we know that your baby is eating enough. How often your baby needs to eat depends on how old your baby is. So a lot of times you'll hear people put different numbers out there about the frequency, but a lot of that depends on how old the baby is, how they're gaining weight. If the baby is a premature baby, all of these factors go into how frequently a baby needs to eat. And as you can see on this log, there's little boxes here for how often we would expect, depending on the day of life, how many breastfeeds should be between 8 and 10 in those first 24 hours, and then the baby should have about 1 pee-pee diaper and 1 poopy diaper in that first day. A good rule of thumb that I was taught was for each day of life, they should have 1 pee and 1 poop. So you'll see that here in the first day it's 1 and 1, the second day it's 2 and 2, and that goes up until about day 7. More is okay. These are kind of the minimums that we are expecting. And then after the day of life 7, the urine in the stool becomes a little bit more plentiful and also a little bit more variable in the frequency of how often they are going. Your baby's weight is another way that in the beginning especially that you will know that your baby is eating enough. One of the reasons why you come to the pediatrician shortly after the baby is born, and then typically 1 to 2 weeks after that, is to check the baby's weight. And that's one of the ways that we know that babies are eating enough. And so the combination of those things will be able to tell you at home. You'll also be looking for how your baby is acting. A baby should offer both breasts at each feeding. The baby will typically become more relaxed. They may start with their hands up here, as I said, the hands and fists moving towards the mouth, and then as they get more and more full, they tend to kind of relax. And you will notice a lot of babies will sort of fall asleep at the breast towards the end of the feeding. And so how your baby is acting towards the end of the feeding will also let you know how if the baby is eating enough. And so we always encourage you, if you have any questions or concerns about this, that's something that you should discuss with your medical provider. Next slide, please. All right.
All right. Thanks, Lisa. All right. So overcoming obstacles. Despite all of your planning, sometimes things are going to go wrong. And what I want to talk about is how you can overcome these obstacles and not let them defeat you. So what you need to recognize is whether the challenges you face are normal bumps in the road or if they're signs of real trouble. So there's not really going to be time to go into every potential problem that you might encounter, but I do want to touch on 3 topics as they seem to be probably the 3 most common issues that tend to come up. And those 3 are sore nipples, engorgement, and babies that are losing weight. So the first one is sore nipples. And I think, as one of you guys already mentioned, at the beginning, in order to make milk, your baby is going to be nursing constantly, almost at the beginning. So it's natural to have a bump in the road, so to speak, that your nipples might be sore while the baby is nursing frequently. But if they get to the point that they are actually cracked and bleeding, then you've gone from normal to not so normal, and you need to get help. Okay. I always like to tell moms that if breastfeeding was meant to hurt as much as some of them allow it to hurt, then our species really would no longer be in existence. It is really not supposed to hurt. And in addition, as moms, we always want to do everything and anything we can for our babies. And so we sort of grin and bear it and say, I'm just going to let the baby latch. But I'd like to point out that if it's hurting that much, then not only are you hurting yourself, but most likely the baby is not latched properly, probably not transferring milk very well. So you should do yourself a favor and get help. Okay. So that's sore nipples. The second common obstacle that women tend to run into is engorgement. And engorgement is also one of those things that can be normal physiologic engorgement, as well as it can be abnormal. And I'm going to go back to what happens at the beginning. I think that most women have trouble in the first week or 2 from the time they're in the hospital to the time that they get to the pediatrician for the first time. So I always feel like the most important part to educate our families on is how to get through that first few days. That's where that breastfeeding log comes in super handy. So your baby is nursing, trying to set yourself up to make a lot of milk. And another thing I always like to tell parents is that your body doesn't know whether or not you've just given birth to triplets or if you had a miscarriage, right? So this is what Dr. Macaluso was talking about, where you need to empty the breast to make milk. I like to point out to people that you need to remove what's needed, or your body is going to do what it's supposed to do, which is make as much as being asked for. So if you have a baby needs to be there nursing. So what can happen with engorgement, normal engorgement, is when your breasts feel full and heavy when they're filled with milk. And then after the baby feeds, the breast softens and it becomes comfortable again. That fullness that you feel during normal engorgement can be heavy and uncomfortable, but is never an excruciatingly painful, terrible thing. Okay, you can get into bad engorgement in a couple of scenarios. One is when the milk first comes in, and I know it's already there, as Dr. Visentin pointed out, the milk is already there, but when it comes in full volume, sometimes it comes in so fast that your breasts get really, really full, and they get so hard that the baby can't even latch on, and you're in a lot of pain, and you put yourself at risk of getting infection. So that milk needs to be drained out, or it's also going to trigger to your brain, like Dr. Macaluso was explaining, that there's no baby drinking, I have full breasts that aren't being relieved, and it's going to turn off the milk production. So that initial engorgement that you get, you just need to make sure you drain them out. Whether you need to do it if the baby does it effectively, great, and if not, you can do it with a pump or you can get help from somebody. And usually things go well. We're just pointing these things out, so just to prepare you for if there are problems. The other time, which is a really fun time to have engorgement, is the first time your baby sleeps through the night, and all of a sudden your breasts will be very, very full and waking you up, and you'll be very happy with that one. The final obstacle that I just want to touch on is when babies lose weight. So Dr. Visentin was talking about how your pediatrician is going to monitor your baby's weight gain, and absolutely your baby's going to gain weight an ounce a day typically, but in the first few days, or the first 4 or 5 days, all babies lose weight. And it's really, really important for you to figure out whether your baby's weight loss is a normal sort of bump in the road that's going to work itself out, or if it's a problem. And that problem could be potentially that you don't have enough milk, you have a low milk supply. It could be that the baby is not removing the milk well for some reason, or it could be that your milk supply is fine and the milk is transferring fine, but for some reason the baby has a medical problem where it's utilizing too many calories and isn't gaining weight from that reason. So your job is to educate yourself, and I think this is one of the most important pieces to educate yourself around. And I'll go back to that breastfeeding log again for a minute, because everybody's going to be giving you advice, good intentioned, but sometimes wrong advice. And if you are familiar with what's normal and what to expect, then you'll be able to say to people, you know what, I'm good. My baby actually is getting enough. The poops have gone from black to green to yellow. There's enough wet diapers. There's enough stool. My baby doesn't need formula. And at the same time, you can look at that log and say, you know what, my baby still has black bowel movements on day 3, something's wrong, okay? So you'll be able to empower yourself to know what's normal and what's not. And if you do identify the fact that there is a problem, that is when you need to do 2 things. Number 1 is you need to feed the baby, okay? Because the most important thing is that you have a healthy baby. But the second part of that is to really figure out what the problem is, so you can identify it. Everybody knows how to fix the problem, give formula, but you owe it to yourself, if you do want to succeed, to try to use a specialist to help you figure out so you can fix it. Because if you give formula without identifying the problem, then you're just going to automatically transition to formula. Next slide. Okay. So getting help, that is the question, right? We gain strength by leaning on our people. So my suggestion is always to surround yourself by supportive people. I like to talk about I think Dr. Macaluso mentioned frequently our mothers have not breastfed, and we frequently lean on our mothers for our parenting advice, but likely she hasn't breastfed, and so she's going to feel a little bit helpless, and so you might need to turn and find some friends who have breastfed, or a support group, or something. And you're not going to know to get help unless you educate yourself, right? So a class like this is terrific. They have more extensive classes at the hospitals, and you can really do yourself a favor and do a personal prenatal visit with a specialist so that you can discuss your individual needs. So everybody has their own medical issues, or they think they're worried about the shape of their nipples, or whatever your personal thing is, you can prepare in advance by doing a prenatal visit to prepare for the baby. It was funny that everybody prepares so much for giving for actual labor and delivery. And I know that's super scary. I've been through it 3 times myself, but that ends. And then you have this baby who's going to be breastfeeding potentially for a long time, and we just sort of wing it and play it by ear. So I congratulate everybody for taking the step and trying to learn. So once you identify that you do need help, where do you turn? And I would say you can look for some resources. Your pediatrician or OB frequently will have breastfeeding support either within themselves, the way we are lactation consultants and also pediatricians, or they may have hired lactation consultants, like Dr. Fierstein has in her office a lactation consultant. So I personally am biased because I feel like everybody deserves to have a visit with Dr. Macaluso, because Dr. Macaluso has taken, she mentioned in her intro, she's taken oh, there she is. She's taken her pediatric training, and she's stopped practicing general pediatrics, and she's really focused now. She found a need in caring for the mother and baby in the beginning of life, because what happens is, after the baby's born, the OB doesn't really take care of the mom anymore. And when the mom is coming to the pediatrician doesn't really know how to take care of the mom. And so Dr. Macaluso takes care of what we call the 4th trimester, that transition from in utero birth to transitioning to life. And she's a wonderful resource, and I encourage everybody. She does prenatal telehealth visits, so you can find her. And one other thing I just want to point out is that whoever you do use for help, it's really, really important to focus on your individual goals. Okay, frequently when you go see a lactation consultant, they just automatically assume your goal is, I want to breastfeed and exclusively breastfeed and blah, blah, whatever their goal is for you. But that's not at all what we should be doing as specialists. And we at Ally have 2 rules, only 2 rules, and that is the baby needs to be fed, and number 2 is that the mother needs to be happy, and everything else in between is negotiable. Okay, we work with moms to figure out what works best for her personal situation. So we'll talk about the risks and the benefits and the pros and the cons, and then we'll talk about how your lifestyle fits in and what's best for you. And then you can figure out which obstacles you can overcome and which ones are not working for you. We find that the only people who give up on breastfeeding when they work with us are people who actually choose to give up. And we support them in that choice because they have made it in an educated fashion. So when you approach feeding in this way, you end up with a feeling of confidence and empowerment rather than a feeling of defeat. And as a new mom, that feeling of empowerment is a really, really important thing to have. It's a very difficult time. So I would just say to remember that if in doubt, you should reach out, and you really do not want to forget to enjoy your baby. Next slide. Oh, you out, no, Lauren, that was my next slide. And then the last slide is questions. So we saved a lot of time for questions and answers because there were a lot of them. So I'll turn it back to Kerry to handle the Q&A.
Great. Kevin, can you make it so that you can see all of us?
Not right now. Here we go. All right, you're all up on screen now.
Hold on. Okay, excellent. So before we get to the Q&A, Jen, do you want to talk about the breastfeeding hotline?
Sure, I don't know the phone number off the top of my head. So Allied Foundation has a support line, which is, it's a not-for-profit. Allied Foundation is a not-for-profit affiliated with Allied Physicians Group, and it's a support line that can answer very basic questions and help you find resources in your community. So if you're looking for a support group or something like that, there are lactation consultants available to direct you, and they have Spanish-speaking and English-speaking lactation consultants. You can find their info on alliedfoundation.org.
Great. Kevin, you're going to make sure that that phone number goes out with everybody when they get the copy of this?
Absolutely.
Excellent.
That, and I'm also going to make sure everybody gets the breastfeeding log.
Okay, cool. Dr. Macaluso, this question is for you. What do I need to know about breastfeeding during COVID?
This was one that I was expecting to come up tonight. So I prepared some notes for this one because it should come up tonight. All medical organizations that deal with infant feeding, the World Health Organization, the CDC, the Academy of Breastfeeding Medicine, the American College of Obstetrics and Gynecology, are providing ongoing interim guidance statements as the COVID-19 virus is a new virus and we're continuing to learn about it. All include in their language that it is the mother and family's choice to breastfeed, even if you're COVID positive or a person under investigation. It's recommended you do your best to prevent transmission to your baby with hand hygiene, mask wearing, and isolating other than feeds if you're positive. Ideally, with another uninfected adult to care for your baby between breastfeeds, including feeding expressed milk. Across the country, hospital policies around separating COVID positive mothers from their newborn infants have been inconsistent. And this is important to discuss with your OBGYN, midwife, and pediatric healthcare team. It's important to include the risks of separation in your discussion. Breastfeeding is the safest, most reliable method of feeding in an emergency. Formula shortages can occur with hoarding and supply chain disruptions. We pass antibodies to pathogens we're exposed to via breast milk, protecting our infants. Breastfed babies have a reduced risk of infections, as we talked about, thus there's less likely a need to seek additional medical care and decreases exposures. Being with your baby with on-demand feeds and skin-to-skin is important in the establishment of breastfeeding for the present and future health of two people, mom and baby. Currently, in my breastfeeding medicine world, I'm definitely finding with the moms having shorter hospital stays that they're receiving and voicing that they're getting a lot less attention. I really feel that COVID has uncovered the importance of thorough mom and baby dyad breastfeeding medicine care. I've noticed a big jump in my prenatal visits. With the shorter hospital stays, families are finding them extremely helpful to go into delivery informed and empowered, with follow-up after delivery to establish breastfeeding and as needed during their journey. And the breastfeeding medicine telemedicine visits have been really helpful during this time. It is so much easier to provide full counseling with full questions answered, easier and more thoroughly when you're not hiding underneath a mask and you can breathe and actually have more give and take. You can also do a heck of a lot with a doll to demonstrate help with latch and positioning. And you can see a lot with the breast and the nipple. We get pretty comfortable pretty quickly in these exams. So you can examine a breast and a nipple pretty well with utilizing the camera on a laptop or on a phone. So once again, I think the field of breastfeeding medicine, recognizing mother and baby as a unit, really recognizing the mom during this critical time, the lack of attention she's receiving in general in healthcare, I like to describe typically, unfortunately, pre-COVID and now, I think it's even harder. You deliver vaginally, and then typically you're told, I'll see you in 6 weeks,
Right.
an OB provider. The pediatrician seeing the baby more, but there's a lot that we're missing between mental health, physical health, and breastfeeding success that women deserve.
Thank you. So Dr. Shaer, this is for you. Given that breastfeeding is so good for my baby's immune system, is it okay if I put off vaccinations?
Love that question. Before I answer that question, though, I just want to also point out one thing that what Dr. Macaluso just said. We are finding, and Dr. Fierstein, you probably are seeing the same thing. Babies are being kicked out of the hospital, moms and babies, literally on like day 1.5. And it's really, really important to get to your pediatrician, breastfeeding or not, really quickly, so that you don't lose, that close follow-up. You definitely need that help. COVID has changed everything. So the question about vaccines and breastfeeding, I love it because actually Dr. Macaluso spoke at the beginning about the fact that breast milk is actually normal. There's this whole belief that breastfeeding is this liquid gold that's going to save your baby from everything. And quite frankly, I always point out to people that before formula was even invented, all babies were breastfed. It just was. And there was plenty of infant mortality back then. So you definitely want to follow the same vaccine schedule as all babies. And interestingly, breastfed babies who get vaccinated, when they get vaccinated, they actually mount better immune responses to their vaccines. So that's a plus, that's a nice bonus. And then I would also throw in that it's important for the moms, safe to get your Tdap, your pertussis vaccine, and your flu vaccines and all of that while you're nursing as well. So you should follow your OB's recommendations on that.
Great, thank you. Dr. Visentin, can you talk about pumping? When they can start pumping and how much they should pump, and giving express breast milk along with regular milk, and then storage. We had another question about breast milk storage.
Sure. And I think there was also another question that was sent about how to actually get a breast pump. So I guess I'll start with that. That most insurances, you can request a breast pump through your insurance. So that's something that you need to contact. There's usually a number on the back of your insurance card for member services, or you can go on their website and contact them. And there's a little bit of a different procedure depending on your insurance. Some of them will actually ship you the breast pump before you deliver. Other ones, they actually have to wait for the baby to be born, and then they get notification from the hospital, and then they ship it to you. So in terms of pumping, some of that is mom's choice and how the baby is doing. For most moms in the first month of life, if the baby is latching on well, there's no medical problems, baby's gaining weight well, I usually tell moms to try to wait on pumping because you're feeding your baby every 2 to 3 hours. Sometimes that process, by the time you feed them, change them, get down again, that may take an hour or more. And so the frequency, especially in those first few weeks, you're recovering from childbirth, you're feeding your baby very often. There's often just not a lot of time to pump. And it can be a big source of stress for moms that they're like, how am I supposed to fit this in? It takes me an hour to an hour and a half to feed my baby. I have to do it every 2 hours. I have to eat, I have to shower. You have to do some other things in there too. So for most moms where things are going well, as I said, the baby is latching on, there's not a problem with mom's milk supply or removal. I typically tell moms to wait that first month to really just recover from childbirth, get your milk supply well established, and adjust to having a baby. After that first month, if moms choose to add in pumping, then they can. Most babies are eating more towards the 2 to 3 hours. The time it takes them to nurse has decreased around that month mark. And so it's just a little bit easier to add in a pumping session. But that said, moms don't have to pump. There's nothing that says, a lot of times people feel like they have to pump or they should pump. And there really is no need to do that unless you're going to be separated from your baby. If you're going to be separated from your baby, which eventually you will, everything's different in COVID times, but my example used to be eventually you'll get a haircut, you'll go out to dinner, you'll do something where you're separated from your baby. That's a little different now, but we'll get back there one day. So yes, if you're going to be separated from your baby, then you would need to pump at that time where you would have otherwise normally fed your baby in order to keep up your milk supply. For moms who are returning to work, they don't need a huge amount of lead time. I know there's sometimes a lot of stress placed on moms. They feel they need to have this ginormous freezer full of milk before they go back to work, and how are they ever possibly going to do that? Do your best to ignore all those photos on the internet. They are sometimes from people who have a huge milk supply, and it's really not necessary. For most moms, if they start pumping once a day, a week or two before they go back to work, they will have plenty of milk stored for their baby. You really need 1 day's worth of milk to go back to work. You have built up that supply in the fridge. You go back to work on Monday. You pump while you're at work, ideally at the same frequency that you were nursing your baby at home. You bring that milk home at the end of the day, and that's what you give your baby for Tuesday. So every day you're sort of replenishing the supply. What you pump on Friday, you save for Monday. And so you really don't need a huge amount of milk stored up in the freezer. There was one other question storage of breast milk. Okay. So you will see some variations in the guidelines. There are different guidelines for babies who are preemies or who have medical problems, but for a typical healthy full-term baby, you can store milk in the refrigerator for about a week. You can store it in a freezer for 3 to 6 months, a deep freezer for up to a year. I usually tell people to kind of treat milk like you would food that was frozen, meat that was frozen. You don't want to refreeze something that was defrosted. Once you've defrosted it and heated it, if the baby doesn't finish it, then you should discard that. You should discard that milk. And I believe on our website we have a little chart that has all of that, how long you can use it for when it's frozen and fresh, and then when it's in the refrigerator.
Great. Just as an addition to that, what do you think about people that say you need to train your baby to take a bottle, so that way when you go back to work, or if you want to leave them with grandma, that they're not screaming all day long?
Yeah. I think you may find different answers from different people, so I'm only going to speak for myself. I believe that babies know the difference between a bottle nipple and a breast. The flow is different, and so I often talk to parents about that breastfeeding and bottle feeding, depending on how you're bottle feeding the baby, can be very different. Most people, let's see if you guys can see this. I think you can. So most people, the baby will be sort of horizontal, and they'll hold the bottle down like this, so the milk is flowing out really fast. And that's a very passive process. The baby really doesn't have to do much. They just kind of sit there or lay there, and the milk just sort of all flows in with the bottle. When a baby is nursing at the breast, they have to actually latch on and suck and swallow. And so they are much more active in that process. And it's not so much that breastfeeding is harder than bottle feeding, it's that the baby has to actively participate in that. And so I will often explain to parents something called paced bottle feeding, which makes bottle feeding a little bit more like breastfeeding. The baby is held a little bit more at an angle. You start with the bottle a little bit more horizontal to the baby, so the baby is actually controlling more of what they're eating. Their sucking and swallowing is making the milk come out, as opposed to kind of gravity just making it all come out when they're holding the baby like this. And so for most babies, they will easily go back and forth between those two, and it's more sort of the flow and how they're being fed that may cause some difficulty, as opposed to them actually getting confused between a breast and a bottle nipple. I tend to think that the babies are pretty smart, and they know what they should be doing.
If I could go to that babies are very smart and they have preferences. Babies up to about 2 weeks will suck on anything. You don't have to worry about them refusing. But I do think if you don't introduce the bottle on some capacity by 6 weeks, that they might have a very hard time accepting it. Some moms have, it's more stressful going back to work if their baby is not enjoying the bottle. So one thing they don't need to get used to formula, but they should get used to by 6 weeks, at least a few times a week, a bottle should be thrown in there, I think, if you're planning to be apart at any point.
Yeah. And oftentimes it helps if it's not the mom who's giving the bottle. It can be mom, but some babies, especially initially, they see mom, they smell mom, they may resist the bottle a little bit more if it's the mom who's giving it. So sometimes I'll suggest that another caregiver try to give it, especially if the baby is having a little trouble with mom doing it.
Great, thank you. Dr. Macaluso, can you talk to tongue tie? One of the moms mentioned that her first child had a tongue and a lip tie, and she wants to know how she can prevent it and or easily identify it and get them the care they need.
So one of the most important things I think when it comes to identifying tongue and lip tie is this brings up once again the importance of breastfeeding medicine and looking at the mom and baby as a unit. One of the main ways that you want to be able to diagnose lip and tongue tie is through strong diagnostic skills and looking at function. Do you definitively have to get a scissor or a laser frenulum revision when you do have signs of restriction? If a baby is feeding fine and tongue function is going well, you do not necessarily need to intervene. There is not a tremendous amount of data out there yet in the areas of lip and posterior tongue tie. Within the Academy of Breastfeeding Medicine and the section on breastfeeding in the American Academy of Pediatrics, this subject comes up quite often, and the headbutting when it comes from different providers and different things that are going on. A lot of us like more of an evidence-based data before we start doing procedures routinely on babies. I like to do a full evaluation of the mom and baby and truly hear out that mom on the symptoms she's having as well. Is she having pain with latch? Does she have nipple trauma? Is she noting her baby to be dissatisfied with feeds? Are feeds taking a really, really long time, prolonged feeds? Is a baby not gaining weight well and not thriving? You look at the baby, you examine the baby. Are you seeing lingual, under your tongue, frenulum restriction? Can that baby lift? Can that baby elevate and cup a breast and transfer milk? You observe a feed, you watch jaw excursion, you watch how the baby functions and performs at the breast. You can do a test weight in our offices, which is a wonderful objective thing you can do where you weigh a baby, feed a baby, and weigh a baby again and see how well they are performing and transferring milk in addition to their weight parameters. It's something that you really want to think through and think hard about. I think it's one of these areas that it's really easy for us to say, okay, at a quick visit, there looks like there's some restriction there. Let's just send you to ENT. It's a quick fix that could perhaps, help things, but it doesn't always help things. And I think that's the other important thing to say is that unfortunately we'll see some kids that don't feel better, that don't feed better after the procedure. And that's an important area that you really need to counsel parents on, that I can't guarantee you after this procedure that you will see 100% improvement. Sometimes it can take time, sometimes you don't see improvement. And that is very frustrating for parents when you diagnose their child with something and it doesn't make the problem better of why they wanted to initiate this procedure in the first place. You will see kids with other differential diagnoses, other diagnoses that are going on. I see a lot referred to me, and a lot of parents will have heard diagnosis of tongue tie or initiate themselves a diagnosis of tongue tie to try to help the breastfeeding experience to be better. And they can have other things going on. They can have laryngomalacia, where a bit of a floppy airway, where that baby's having a hard time coordinating suck, swallow, breathe, has inspiratory stridor, and is having a challenging time feeding. These are all the things I've seen that present with a rule out tongue tie, and it ends up being something else. Kids with congenital heart disease that can have a hard time and shortness of breath and difficulty, once again, having the energy to feed and show subtle signs of retractions and working to breathe while they're eating. And sometimes I've seen those kids come in because they present with poor weight gain and somebody is, pushing for a tongue tie diagnosis. So it's really important to think of a full differential diagnosis, look at mom and baby through a detailed history and physical exam, and really think long and hard of what the data shows on, if I do this procedure, what outcome can I predict, promise, and really have an evidence base to initiate for a family. We do have pretty good data and definitely clinical experience for most of us in the breastfeeding medicine world of those showing definitely more predictable positivity improvement after. But we still have, you know, a grounds way to go in terms of data and evidence base for posterior tongue tie and lip tie.
I also wanted to add that you mentioned, you know, if there's a tongue tie and, you know, you've decided and you're going to get it repaired and you said to go to the ENT, I wanted to mention that there is no advantage of a laser, even though it sounds really cool and futuristic, that, you know, going to somebody that has a laser that's out of network that costs you lots and lots of money is not superior in any way to going to an ENT or a pediatrician or whoever it is that's comfortable, that really just snips it, and this should be covered by insurance.
Yeah, there is no evidence base yet, research data out there to show laser superiority to scissor.
Right, or even anecdotal evidence among the rest of us, right? Speaking of covered by insurance, somebody asked, how expensive is it to get a lactation consult or visit, because they wanted to budget? Dr. Shaer, you want to take that one?
Sure. Well, I think, you know, different lactation consultants in the community charge variable amounts, but since we're all physicians, you can see any physician who's a lactation specialist as long as your insurance, we're on your insurance plan. It's a copay. Yeah, that's really it. I mean, lactation consultants in the community will charge anywhere from $150 to $300 typically, I think, for a home visit.
But basically, anybody who's listening could have a prenatal consult with Dr. Macaluso or see any of you for the cost of their copay. Although actually it's 2 copays, right? Once the baby's born, you usually do the baby and the mom.
Right. Depending on what the issue is, right.
Well worth it.
Yeah.
Dr. Shaer, can you talk about how do you get the baby to sleep through the night faster, or what do you do when the baby's days and nights are confused?
Sure. So it's to back up to, I think when Dr. Visentin was talking about the baby's constantly feeding and it's every 2 hours and where will I find time to pump, it occurred to me that those are issues related to any baby, breastfed or formula, right? And when you're a new parent, you shouldn't really expect to sleep at the beginning. Your job is to pretty much feed your baby. So the breastfeeding part is actually easier because you don't have to get up in the middle of the night to prepare the bottle and wash the bottles, and you just kind of have everything you need right there. How do you get your baby to sleep through the night? Was that the question? Yeah, so you don't really get your baby to sleep through night at the beginning. When they get a little bit older, you can do sleep training and things like that. But at the beginning, if your baby wakes up, you should feed them and put them right back to bed.
Okay. Dr. Visentin, so we've talked a lot about breastfeeding. What about the mom who wants to do breastfeeding and formula? Mm-hmm. Is that a terrible thing?
No, that's mom's choice. It's not. And our goal is to educate moms and to make sure that they understand the potential impact on their milk supply if they are giving formula. As we've mentioned, Dr. Macaluso mentioned earlier, how much milk you make is determined by how much milk is removed. So when babies are given formula, if moms are not pumping to then also remove that milk, then the signal is being sent to the body, I don't need to make as much milk. So as long as moms understand that introduction of formula has the potential to decrease their milk supply because that milk is not being removed by the baby, if it's mom's choice to introduce formula, then that's okay. And that's her choice. We try to do some of these webinars and talk to moms so that they understand the potential impact on their milk supply, because a lot of times people don't, and they're told, oh, just give a bottle and it's okay. And then they're getting a bottle more and more because they feel like they're not getting, the moms aren't making enough milk. And part of the reason why they're not making enough milk is because the baby is getting bottles of formula, and that potentially that wasn't explained to the mom. So as long as moms understand that, and then that's their choice, absolutely. As long as that baby is being fed and healthy, then that's our ultimate goal.
There's one piece to that in terms of educating yourself, and that is that when you do add formula, if it's your choice, that's fine, but adding formula does decrease some of the benefits of the breast milk. So the exclusivity of the breast milk in the first months is really the gold standard. It's absolutely fine to add formula, but you have to know that you are giving up some of those benefits. It does take away some of the factors that the exclusive breastfeeding grants you.
Great. So I think that's a great note to end on, that moms have choice, that when you work with a lactation consultant, they're not going to push you in one direction or the other, but give you the information that you need to make an informed choice. Because as a parent, that's what you have to do. You have to weigh the pros and cons, the risks and benefits, and you need really good information. And a lactation consultant who also happens to be a pediatrician is a really great place to get that information. Kevin, was there anything else that we need to get to from the questions? I think we did a pretty good job.
I think we did a really great job. Again, thank you all of you for providing this, this information. It was awesome, and we're getting responses saying thank you so much. So appreciate everybody taking the time this evening to join us. Keep on the lookout. We're in another month. We're going to have another webinar coming out in our series, and we wish everybody stay safe and healthy during these times. And I will follow up with the breastfeeding link to this webinar, as well as the feeding log and our foundation's breastfeeding hotline number.
Excellent. Thank you, panelists, and thank you, everybody who listened tonight. And thank you, Kevin, Adjuvant, and Allied. Bye, everyone.
Bye.
Bye.
Bye.